Hello everyone. Let's continue the rest of sympathomimetics. We are still talking about direct-acting sympathomimetics. In the past video, we illustrated adrenaline in detail because it is a prototype, and I told you after we are done with adrenaline, we will begin discussing the rest of the family in brief. The second drug we have after epinephrine, look, in this video, we are going to explain the following drugs. Number 1, noradrenaline or norepinephrine. Number 2, we will talk about dopamine. We will talk about dobutamine. We will discuss beta-2 agonists, whether they are selective or not. Number 5, we have dopamine receptor agonists, but before them, we have alpha agonists. Then we will discuss dopamine receptor agonists. These are the drugs we are going to talk about in this video. So let's begin with noradrenaline or norepinephrine. When we talk about norepinephrine, it's typically the cousin of adrenaline. Both of them share nearly the same structure. They contain the same ring, the catechol ring. When you want to talk about the chemistry or pharmacokinetics of noradrenaline, it's exactly the same as adrenaline, not absorbed orally, doesn't cross blood-brain barrier, can be taken orally as tablets, it must be given by injection, and so on. Also, it shouldn't be exposed to the air for so long or else it's oxidized, turning into the substance that you saw, the dark substance called adrenochrome. However, the core difference between adrenaline and noradrenaline is the mechanism of action. When you read about norepinephrine, you can see it acts on alpha-1, alpha-2 and beta-1. However, it doesn't have beta-2 or beta-3. These are not present. It acts on these, okay? And I told you in the past video, there is no drug acting on the receptors that has an apparent effect on alpha-2, except, by the way, when you want to induce an effect on alpha-2, then design a drug for it. Design drugs called selective alpha-2 stimulants or agonists. However, most of the drugs affect more than one receptor. When they reach alpha-2, it's hidden, so the effect is not prominent. And if you want to be more accurate, then noradrenaline acts mainly on alpha-1. Between you and me, we can consider that 90% of its action is on alpha-1. And you know that alpha-1 causes vasoconstriction. Thus, the main effect of norepinephrine is vasoconstriction. Regarding its effect on beta-1, it has some effect, but not as much as it has on alpha-1. So between us both, we can consider it 10% or even less than 10%. In conclusion, when you administer noradrenaline, its effect is prominent only on alpha-1 and beta-1. A drug with such a character, being very short-acting, exactly like adrenaline, and is also destroyed by Mao and Comte within minutes? What is the use of a drug with such a character? A drug which says, I am devoted to alpha, my function is vasoconstriction. That's why the main use of norepinephrine is to induce vasoconstriction. We use it for this purpose. But for who? For people with acute hypotensive states, a patient who is in ICU. Not for any normal person complaining of some hypotension. We don't give anyone with hypotension norepinephrine. No, it's for the acute hypotension when he is in the ICU, so not for any usual case. Norepinephrine being highly aggressive, it's prohibited. Again, it's prohibited to be administered by direct injection. It is present as boluses, exactly like adrenaline, however, it's prohibited to be given subcutaneously. Do you remember adrenaline? We could administer it by subcutaneous or intramuscular injection. Here it's prohibited. Thus, it cannot be administered orally, nor subcutaneously, nor even intramuscular. Then how can we use it? The only way to administer noradrenaline, when it's indicated, it is by bringing a bag of saline or glucose, 500 millimeters. Here, like this one. This is a blue saline bag of 500 millimeters. Hang it to the patient and add to it the bolus of norepinephrine. Here is a device called intravenous set or dripping set. It attaches here. Then you can give the drug to the patient by dripping, drop by drop, to the vein. So you don't administer the bolus directly. You don't give this bolus itself by IV. Why are we saying this? Because if you give this bolus by direct subcutaneous injection, it causes severe vasoconstriction that can lead to something called tissue necrosis. The area where you injected norepinephrine dies. If you injected it concentrated like this directly subcutaneous, this area dies. It turns blue, then undergoes tissue sloughing, and the drug won't be delivered. And so many problems occur due to this severe vasoconstriction. That's why it should only be added to an intravenous fluid, and here is a controller and a wheel in order to adjust the rate. 20 drops per minute or 30 as you like, and tell the nurse to measure his blood pressure every 15 minutes. Because it's probable that norepinephrine highly elevates blood pressure suddenly, and if the pressure is highly elevated without control, it could lead to cerebral hemorrhage. So keep focused on the precautions of using norepinephrine. If an examiner asks you how do we administer adrenaline, tell him it can be given subcutaneously or by intramuscular injection and sometimes by inhalation. But if he asks about noradrenaline administration, never tell him subcutaneous nor IV nor even intramuscular. Tell him the only way is to add it to an intravenous fluid, then give it by something called intravenous dripping. This method is called intravenous infusion. There is a difference between saying IV like this means giving a syringe directly into the vein, but if you add an I, then it becomes intravenous infusion, which means the drug is added to these 500 milliliters of solution, then it flows very slowly to the vein. This is called intravenous dripping. We have an important note in physiology. Take care of it because it's the subject of so many questions which we like to confuse you with. We have some laws in physiology. Among them is the law of Baroreflex. You studied it before. Baroreflex. What is this Baroreflex? This law states that any reason elevating the blood pressure suddenly, if the blood pressure is elevated suddenly, say from 120/80 into higher values, this elevated blood pressure must send to the brain to cause a reflex bradycardia. The heart must slow down. But what are the components of this reflex? This is the aorta arising from the heart, here is the aortic arch, and there is something called stretch receptors. Once the pressure is highly elevated, these stretch receptors must send to the cardioinhibitory center present in the medulla, telling it, watch out, the blood pressure is highly elevated, and if the heart keeps this degree of activity with this elevated pressure, it could lead to a problem called acute heart failure. It could lead to aortic avulsion. The aorta is ripped out of the heart. It could lead to something called aortic dissection, intimal dissection. The aortic intima is teared longitudinally and is cut. Why? Because this bumping heart cannot withstand to keep this degree of activity with an elevated pressure. That's why God is blessing you with a protective mechanism called Baroreflex. Once blood pressure is elevated, the stretch receptors in the arc feels this elevation and sends to the cardioinhibitory center, which then sends to the heart causing bradycardia. This reflex arc is carried out by the vagus nerve. That's okay, but there is an important condition for this reflex to occur. This elevated blood pressure must be elevated suddenly, not chronic, not from something about 2 or 3 years. If someone has elevated blood pressure since 2 years, this elevated blood pressure won't cause bradycardia. For this reflex to occur, blood pressure must be elevated, say from 120, suddenly exceeding 170. And systolic blood pressure must exceed 170. Below this value, this reflex doesn't occur. So I have two conditions for this Baroreflex to occur. The first one is the rise in the blood pressure must be sudden. The second one is the value of systolic pressure, which must exceed 170. Because by time when pressure is elevated and the patient leaves it like this for years, yes, bradycardia occurs at first, but by time adaptation sets in, this reflex begins to disappear and fades away, so the patient's pressure could be 190 and the heart is working normally with its normal rate. Where did the reflex go? It underwent adaptation. Now there is a drug called atropine. We will discuss together this atropine in the parasympathetic, where you will learn that it's a muscarinic blocker. It blocks the vagus nerve. So it's a catastrophe to give noradrenaline or anything elevating the pressure, not a noradrenaline alone, but anything that could elevate the blood pressure. It's a catastrophe if the blood pressure is suddenly elevated while the patient is atropinized. Why? Because now he doesn't have this reflex. This Baroreflex is broken since you blocked it by atropine. So a drug like norepinephrine would suddenly elevate the pressure while this reflex is blocked, causing aortic dissection or acute heart failure or whatever happens to the patient. We like to ask students about this concept in MCQ exams, so keep focused. We might ask you about this reflex. This reflex bradycardia is caused by. The answer would include any drug that elevates the blood pressure. By the way, this reflex bradycardia isn't inclusive for norepinephrine alone. It's a physiological reflex that occurs in response to any sudden elevation in the blood pressure. Whatever the cause, either a drug or emotion or whatever, it's linked to a sudden elevation in the blood pressure exceeding 170. Be also aware that it's mediated by the vagus nerve and blocked by atropine, which is very dangerous in this situation. This is what you need to know about norepinephrine. We updated and removed many parts from your old textbook, so don't confuse yourself with unnecessary information from old sources. We are giving you the most recent concept that you need to know in order to eliminate the burden of unnecessary information. Now let's shift to the next drug called dopamine. Dopamine is also a member of the same family. If you remember from the past video, I told you we have something called tyrosine. This tyrosine turns into something called dopa. Dopa turns into dopamine, do you remember? And then dopamine into noradrenaline, then adrenaline. And I told you all of these have the catechol ring, and they all obey the same rules. They are not absorbed orally, don't cross blood-brain barrier, and so on. Accordingly, dopamine is originally one of these catecholamines. It contains this catechol ring and obeys the same rules. If we want to talk about dopamine regarding physiology, functions in your body, sites and so on, 10 hours wouldn't be enough. Thus, we are not going to discuss physiological properties of dopamine. We won't discuss right now the functions of dopamine in your body. On the other hand, we are going to discuss the bolus which we invented from dopamine. In other words, how does external dopamine affect your body? Very briefly. And when we reach dopamine during CNS chapter, then we will explain it thoroughly. But for now, all you need to know is that the drug called dopamine is already a natural compound, and we turned it into a drug exactly like what we did with adrenaline, and it's a catecholamine, which means it is a member of the same family. Now be aware that regarding its mechanism, dopamine is slightly different from adrenaline and noradrenaline. Where does the difference come from? That's because dopamine acts in your body according to the dose that enters your body. The amount used, the amount of dopamine that enters your body is what determines its action. So when this dopamine is given in a low dose, a small one, in the past we used to determine its value, but we removed this number because, for you, it doesn't matter. We will never ask you about this dose or how it's calculated. This information is of no significance for you. All what you need to know is when we use a low dose of dopamine, it enters your body and acts on a receptor called dopamine type 1. Dopamine has different types of receptors in your body. 5 types of receptors: dopamine type 1, 2, 3, 4, and 5. 5 receptors. Thus, this low dose that you use, and I'll tell you how to use it, goes to D1, stimulating D1. Now the place that has the most dopamine type 1 receptors in your body, and the first one to be affected by this dopamine, is the renal vasculature and the mesenteric blood vessels. You already know renal, so mesenteric means the blood vessels in the mesenteric area. Mesenteric area is the abdomen. Those are the blood vessels supplying the spleen, the pancreas, the liver, or the intestine. All of these are called mesenteric vascular bed. All of these are filled with dopamine type 1 receptors, and when dopamine type 1 receptor is activated, it causes vasodilatation. Again, dopamine in a small dose causes vasodilatation in the renal and mesenteric vascular bed, and we will see the benefits of this. However, if it is slightly increased, now called intermediate dose, which is a moderate dose, a little bit more than before, again for the second time we remove the value of this dose. The intermediate dose goes to the beta 1 present in the heart, increasing the cardiac output. We will also state its benefit soon. Furthermore increase, which is now a high dose, now dopamine starts to swing at alpha 1 causing vasoconstriction, increasing your blood pressure. So dopamine acts according to the dose. Low dose, how much is low dose? It doesn't matter. It acts on dopamine receptors in renal and vascular bed causing vasodilatation, and it may increase the urine output. Because when you induce vasodilatation in the renal artery and renal blood vessels, you increase the urine output. Intermediate dose activates beta and high dose activates alpha 1. Note that they all have 1, no 2s. D1, B1, alpha 1, all in the same order, exactly like the name. So you may never forget it during exam. It's called dopamine. The first letter is D, thus at first in a small dose it goes to dopamine receptor. This P considered B, which refers to beta, so it later goes to beta, and this A is for alpha, so at first it goes to dopamine, then beta, then alpha. This is according to the order of the receptors. Now let's see how can we use dopamine and take advantage of its properties, and how can we administer the dopamine when it is indicated. Firstly, this dopamine, which we invented and is externally administered, is made almost for a single purpose. It's almost exclusively made for patients in something called shock state. Shock state in medicine? When you say shock, it means sudden upsetting or surprising event. However, to be more scientifically accurate regarding the medical definition, what is a shocked patient? A shocked patient means a patient with hypotension, low blood pressure, but this is not the core of it. Instead, you must add to it impairment of the tissue perfusion. Blood is not sufficiently reaching the internal organs. There is a huge difference between a patient who is just hypotensive, just low blood pressure, and a patient who is shocked. This one is far more dangerous. Why? Because blood is not reaching the internal organs like kidneys, mesenteric vascular bed, liver, or pancreas. This could lead to ischemia and tissue damage if you don't interfere. But how can we identify a shocked patient? When a patient goes to a hospital to check his blood pressure, either if his blood pressure was just low or if he is shocked, in both cases, the patient looks drowsy or somewhat disoriented. However, you can identify the shocked patient by asking him, "When was the last time you urinated?" He might say a moment or a short time ago. This means the blood is reaching the kidneys and they are forming urine, thus most probably this patient is not shocked. But then another patient may tell you that he didn't go to the bathroom since 2 days. Here you should start doubting. Observe the patient. Look at his hands. They would be pale and cold. We all have pink color on the palm of our hands, reflecting the state of the circulation. Blood color is always reflected in the palmar side of the fingers. Shocked patients, in addition to oliguria which means little urine output, or sometimes anuria, which means no urine at all. Or sometimes anuria, which means no urine at all. Any one of us, when he presses in his finger like this, it turns white. This white color is because of the blood running from these pressurized areas and then the blood fills it again. This is called capillary refilling. Capillary? Like this. Capillary refilling. When you release the pressure from the finger, capillary refilling occurs, but in the shocked patient, since the blood is not capable of reaching the internal organs and he has impairment in the tissue perfusion, then when you press on this finger like this, it turns white due to the pressure. However, this time the circulation doesn't come back, or it comes back very slowly. And in addition to cold hands, he may also be sweaty, and he tells you he didn't go to the bathroom since yesterday, so he has oliguria or anuria, no urine at all. Oliguria means urine less than 500 milliliters per day. The bare minimum of daily urine output is half a liter. Lesser than this is called oliguria, no urine at all is called anuria. All of these point the shocked patient out. Now, if I ask you during an oral exam or whatever, in a shocked patient, what is your goal of therapy? What's the aim of treatment? A student may tell me the aim is to restore the blood pressure. This is a mistake. This is not the main aim of the treatment. Restoring the blood pressure is not a problem. However, our main purpose is to restore the tissue perfusion firstly, to ensure that blood is reaching the internal organs, because this is where the danger comes from. The problem arises from this point. So answer me like this. Shock state means hypotension associated with impairment of tissue perfusion. My goal of therapy is to restore the tissue perfusion at first, rather than correcting hypotension. After this, we fix the hypotension. Now I explained to you what does it mean to have a shock. So let's see what are the benefits of dopamine. Imagine if this patient came to you at the hospital, a shock patient. You'd give him dopamine, exactly like norepinephrine. We bring 500 milliliters bag of solution, like this bag. Bring the dopamine vial, which has about 500 milligrams or 200 milligrams, whatever. Add it to this solution and hang it to the patient as intravenous infusion. We give it to him slowly by dripping. The wheel or the controller present here controls the rate of dripping. Okay, now this dopamine is dissolved in the solution and you're giving it slowly to the patient after adjusting the rate to about 10 drops per minute. Try this at first, don't rush it, give him 10 or 15 drops per minute at first. This little amount of dopamine is a small dose. And to where does the small dose go? I have just told you, that small dose will go to the dopamine type 1 receptors, which are present in the renal and mesenteric area causing vasodilation. After inducing vasodilation, urine output increases. Thus, you ensure to restore firstly the tissue perfusion for the kidney and the mesenteric area. With the first amount of the drug, you ensure restoring the tissue perfusion with the first amount of dopamine. Then, after a while, after dopamine enters his body and starts to build up, the amount is increased. Then it goes to the beta 1 increase in the cardiac output. This is very good because increased cardiac output contributes in further correction of tissue perfusion. After some time, when the dopamine is highly increased, it goes to the alpha 1 causing vasoconstriction and starts to fix the blood pressure. Do you see in what order does dopamine fix the patient? We always say that dopamine is a smart drug. It may sometimes understand the situation better than the doctor who is given it, because the dopamine understands the case and knows how to manage it. Once you administer the dopamine by intravenous infusion, firstly it goes to the renal and the mesenteric area, opening them, because there is a problem in them, there is a tissue ischemia. That's why dopamine acts on them before anything to ensure them. Then it increases the cardiac output and then it suffocates the blood vessels controlled by alpha because they are of no use right now. Where is this alpha? It's mainly present in the skin and submucous blood vessels. Thus, when it suffocates these two, then the cardiac output goes to the opened area, which are the only open blood vessels are those of the renal, mesenteric and other vital organs. Thus all of the blood shifts to them, leading to an increase in the urine output, ensuring that the patient don't develop renal failure. Many of you guys make this mistake because you are rushing. For example, a patient with hypotension comes to the hospital and when you measure his blood pressure you find him hypotensive. And you consider him an ordinary case of hypotension and prescribe any drug elevating the blood pressure. I could raise the pressure by noradrenaline, for instance. Instead of this dopamine, I could use noradrenaline. However, noradrenaline wouldn't fix the shock. Norepinephrine only corrects the hypotension superficially. After 15 minutes of norepinephrine, his blood pressure begins to normalize, so you think you treated him. So you shake hands and tell him congrats, goodbye, go home. He goes home and then the next day he comes back to you with renal failure. Why? Because you corrected his blood pressure superficially. However, organs are still deprived from blood. Thus, the patient went home with tissue ischemia and stayed like this for a day or two until he developed renal failure. That's why dopamine is the best option for shock. You may encounter a question in the final asking you to mention the mechanism of action with the names of 5 or 6 drugs, asking you to mention the mechanism of action of each one in the following conditions. And beside each drug is a case. Say dopamine for shock. What does dopamine do in shock? If you are a smart student, always remember when I ask you about the mechanism of a drug in a certain case, at first, show me 2 lines illustrating this case. Show me you understand it. For example, dopamine in shock, tell me about it, then tell me its mechanism. Don't go directly for the mechanism. Firstly, tell me what does shock mean. Tell me shock is a state of hypotension associated with impairment of tissue perfusion. This is the first line. And the second line, to show me you understand, my goal of therapy is to correct tissue perfusion at first, rather than correcting the blood pressure. Firstly this, then we correct the blood pressure. Then shift to the dopamine and tell me what does it do. Tell him the effect of dopamine in a small dose on D1 in renal and mesenteric, then it increases the cardiac output, then it induces vasoconstriction, correcting the blood pressure. This is how dopamine fixes the case, starting from the most important point, which is vasodilatation, until it corrects the blood pressure, not the other way around. Look at this mistake made by some people. He hangs dopamine to the patient and gives him maximum rate. A doctor or a nurse in a rush may add dopamine in a rate of 60 drops per minute. 60 drops per minute is a very high dose. This is called alpha dose. What does alpha dose mean? It means all of this amount enters directly to alpha bypassing B1 and D1 goes on vasoconstriction, which corrects the blood pressure instantly. So you think the patient has improved and discharge him, while the blood hasn't yet arrived to the renal sufficiently and the mesenteric vessels. That's why you shouldn't rush while using dopamine. Add the dopamine to the solution, then give it at first by a rate of 10 drops per minute. And then when you see the urine begins to be corrected and the patient's circulation begins to be fixed, when you find the normal capillary filling, he is no longer sweaty, his temperature improved, that disorientation is subsiding and he starts to wake up. Then you aim for the blood pressure and do whatever you like because you are now sure he won't develop renal failure and so on. This is the dopamine. And again, no one will ask you about the dose at all. All what you need to know is its effects in a small dose, intermediate dose, and in a large dose. Don't bother with numbers or any calculations at all. The next drug we have is Dobutamine. Dobutamine is the little brother of dopamine. It is also synthetic. By the way, Dobutamine is a catecholamine, but it's a synthetic. Look here. Instead of wasting our time explaining Dobutamine, let's just compare it to dopamine. This is the dopamine. Dopamine? And here is its little brother, Dobutamine. You may find this comparison in your exam paper, a small comparison for a 1 mark or 2, asking you to state the difference between two drugs. This dopamine is a natural cat. Natural cat means natural catecholamine, while this one is a synthetic cat, which means it is a synthetic catecholamine. That's why dopamine takes the letter B for buck, while this has P for pen. Why is that? Because this one's natural, originating from dopa. This is natural compound in your body originating from dopa, thus it's natural. While this one is a man-made. It's not originating from dopa, but from other chemical compounds. So if we had named it with P for pen, you would have thought it is originating from dopa, and it's natural. That's why the Global Council for Drug Naming gave it the letter B. B for book. In order to avoid this confusion, draw a line. The next point is, as we know from its name, dopamine acts on D1, then B1, then alpha 1, while dobutamine is almost exclusively acting on beta 1. So it acts on cardiac beta 1 only. Accordingly, its function is to increase the cardiac output, and you can also say heart rate. However, it mainly increases the contractility rather than the heart rate. Don't bother with this. At least know that dobutamine don't act on D1 nor alpha 1. It doesn't have a vascular effect. Draw a line. What did you use dopamine for? I told you in cases of shock. And by the way, we will explain all types of shock in cardiology chapter in detail. But as I told you, here I'm giving you a general idea about the sympathomimetics. In a case of shock, especially the septic shock means a hypotensive patient with insufficient blood supply for the internal organs because of severe infection. It's called septic shock and we will discuss it later in detail. While this dobutamine, which only acts on beta 1, as you know, its effects are only on the heart. That's why it's used when the shock is due to a cardiac cause, which is called cardiogenic shock. What does cardiogenic shock mean? Again, I told you cardiogenic shock means low blood pressure and blood's not reaching the internal organs. And I told you it has so many causes. We will discuss it later when we reach the cardio. But you should know that one of its main causes is cardiac insult, a major problem in the heart, lowering the blood pressure and blood supply. For example, Patients with myocardial infarction. Infarction is a dead part in the heart. This all of sudden dead part was due to coronary insult or whatever. It led to severe myocardial depression, so the heart went down. Now it's not capable of contraction, and a not contracting heart means no blood supply for the internal organs. Accordingly, the patient is hypotensive with impairment of the tissue perfusion, so he's shocked. What do we call this type of shock that's caused by the heart? It's called cardiogenic shock, and since you know the reason, assuming that you could correctly diagnose that the cause of this shock is something cardiac related, so instead of using dopamine, it's better to use dobutamine. Why? Because it's the specialist in beta 1. Since the cause is in beta 1, something in the heart we call pump failure, then give him a beta 1 stimulant such as dobutamine, which increases the contractility and wakes the heart up. And of course we administer it by the same way. It's also prohibited to be given like this. To give dopamine or dobutamine directly? No, they must be added to a fluid. So if it's a cardiogenic shock, then it's the dobutamine. Then if you are asked to compare between dopamine and dobutamine, we have three differences only. Dopamine is a natural cat. This is a synthetic. Dopamine acts on 3 receptors according to the concentration used. On the other hand, dobutamine in a small or large dose, it acts on beta. Dopamine can be used in any shock case generally. Any shock case, whatever the reasons are, use dopamine. However, dobutamine is only used for single type of shock cases, which is caused by the heart and called cardiogenic shock. That's okay? And I don't want to repeat again that these are catecholamines, only last for short periods of time and must be given by intravenous infusion, again and again for you to remember. The next drugs after dobutamine are going to be beta receptors related. I'll tell you about a class of drugs called beta 2 agonists. Beta 2 means they are going to stimulate beta 2 receptors. Now let's divide beta 2 agonists, and we are generally talking about drugs acting on beta receptors. There are some drugs that stimulate beta 2 receptors and called selective beta 2 agonists, and there are some drugs that stimulate beta 1 and 2. Now, if I may trick you and ask you, is there any drugs stimulating beta 1? Yes, there are drugs stimulating beta 1 only. Like what? I have just told you 2 minutes ago, dobutamine, it acts on beta 1. Thus, if you are asked about drugs acting on beta receptors, tell him there are drugs acting on beta 1 like dobutamine, as I told you a minute ago. There are drugs acting on beta 2, we will discuss them in a minute. And there are non-selective drugs that stimulate both beta 1 and 2. We have explained dobutamine, right? So let's shift to beta 2 agonists. These drugs which act on beta 2 are important, and they are a wide class of drugs with so many names, so be patient with us. Number 1, a drug called salbutamol. Another drug is called ritodrine. Third drug is called terbutaline. There is also salmeterol, formoterol, bambuterol, and so on. They end with tirol. Let's separate this one, ritodrine, and mark it with red color. Although it's one of them, I want to distinguish it a little bit. What are beta 2 agonists again? Salbutamol, ritodrine, terbutaline, salmeterol, formoterol, bambuterol. First of all, these are non-cat. Non-cat means they are not catecholamines, so forget about what you know about the catecholamines. Accordingly, these drugs can be given orally. They are absorbed, their duration of action is long, they are not destroyed by mouth or comb, they don't obey the previous rules, okay? Some of these drugs, like this salbutamol, last for about 4 hours in your body. It's not destroyed by mouth or comb, by the liver. And there are other drugs like this salmeterol that last for 12 hours. So among them there are drugs with relatively short durations and other with relatively long durations. These drugs that are not catecholamines, and you can use them as pills, inhalers and syringes, however you like. And they stimulate beta 2, and I say beta 2 only because they are selective on beta 2. When you stimulate beta 2, what do you think can happen to your body? Remember with me, where was the Clin beta 2? And all what you know from the video in which we explained beta 2 is going to occur. For example, if I choose blood vessels, what would you say? You would tell me it causes vasodilation. But where? You would tell me in the skeletal muscles blood vessels. Not only in there, but also in the coronary artery, because the coronary also has beta 2. Okay, and what else? The uterus. It has beta 2, as I told you. It causes relaxation. What else? You told me this. Tremors. Tremors of the hand. They are caused by beta 2. What else? You tell me they enter the liver and melt the glycogen elevating blood sugar level. This is also caused by beta 2. What else? They go to the blood potassium. These drugs draws the potassium out of the blood, transferring it into the muscles. What else? They go to the lung, the bronchi, and causes bronchodilation. All of these effects are caused by beta 2. All of these drugs can cause all what I mentioned on the board. However, are you going to use all of them in all of these situations? Of course no. We mostly use them only for two indications. Two situations or two indications for the use of the selective beta 2. These are the most well known. The first one of them where we use these drugs in, and one of the most well known use, is in bronchial asthma. Bronchial asthma is chest allergy. Why? There is a long chapter dedicated only for the bronchial asthma. It's not the time now to discuss bronchial asthma in detail, but at least you know bronchial asthma patients suffer from bronchoconstriction, thus you want to induce bronchodilation. Very simple. And you have these specialized drugs. They specialize in beta 2. And they are present as tablets, inhaler, whatever the form the patient desires. So the first indication of them is the bronchial asthma, with all of its types. We will discuss it in detail when we reach the respiratory system, okay? The second indication is when you want to induce uterine relaxation during pregnancy. Some women, when they get pregnant, they experience repetitive abortions. This is called habitual abortion. Habitual abortion means repetitive abortions. Here, uterus is weak. So whenever she gets pregnant, for any reasons, some uterine contractions occur and she undergoes abortion. One time when she's pregnant, she goes to the obstetrician. The obstetrician tells her to rest and not to exert any effort. In addition, I'll give you external drug that causes uterine relaxation. This drug stimulates beta 2 within the uterus. Which one of them? Of course, they all can be used. Those 5 or 6 drugs I mentioned before can be used. Salbutamol, terbutaline, ritodrine, salmeterol, bambiterol, formoterol, albuterol. All of these drugs could be used. However, this one that we choose specifically for the uterus and the most well known for this effect. It is the one among them which I marked with red a while ago to distinguish it. The one called ritodrine. So this ritodrine is a beta 2 stimulant to relax the uterus. This is given to delay premature labor or to prevent an abortion. Delay premature labor is the same as this. If you are afraid that some woman would give birth at 6 or 7 months, she's a pregnant woman at 7 months but her uterus is not able to carry on. So the doctor describes her a beta 2 in order to cause some uterine relaxation to extend this pregnancy. Instead of giving birth after 7, it could be after 8 or 9 months. This is called premature labor. Accordingly, we use the ritodrine either to prevent an abortion or to delay a premature labor. Okay? Now allow me to ask you what are the downsides of these drugs, collectively as a class. These drugs called beta 2 agonists, what are their downsides or the adverse effects that you expect? The adverse effects you expect, and I want you to add some more to your textbook. We have 3 T letters and 1 H letter, 3 T's and 1 H. I am talking about the adverse effects or the disadvantage of this class. The first T is for tachycardia. Tachycardia and arrhythmia. What? Are you saying tachycardia? Why? Doctor, didn't you tell me that they act on beta 2? I'll tell you yes. So you'd ask me, then where did this tachycardia come from? I know tachycardia is caused by beta 1. I'll tell you, you are right. However, you didn't notice that I told you these drugs stimulate beta 2. I hid something from you. They can lose their selectivity and swing at beta 1. But when does this happen? When you increase their dose? If their doses are increased, they lose their selectivity. They start to act on beta 2 and beta 1 causing arrhythmia and tachycardia. So that some people with bronchial asthma who takes these drugs, his breathing is heavy. So he takes the inhaler constantly, but he's not relieved, so he increases the dose more and more and more until at one moment he complains of tachycardia. His hand starts to be shaky. Thus, he calls his doctor, complaining from his heart and rapid pulse. Then the doctor reassures him that these drugs only act on beta 2. Wrong! These drugs act on beta 2, however, when you increase their dose, they start to lose their selectivity and go to beta 1, causing tachycardia and so on. This is the first adverse effect you should be aware of. The second adverse effect, as I mentioned before, is tremors. And you know that this shaky hands make sense due to beta 2 effects. The third T is for tolerance. Tolerance. What does tolerance mean? This term tolerance will be explained more thoroughly in the general chapter. But for now you should know that tolerance means the body starts to be accustomed to the drug. Day after another, the usual dose is no longer producing the desired effect and the patient must increase the dose in order to get the desired effect. Day after another, the patient keeps increasing the dose until he suffers from these side effects. This is tolerance and it has many causes. We have a rule stating that the more you target receptors with a selective drug and stimulate them day after another, the less their numbers become. If this is a cell like any cell in your body, if it contains 100 receptors and each day I stimulate these receptors with a drug, day after another they become 90, they become 80 and so on. This is called down-regulation. Down-regulation of the receptors. Which means their numbers and their sensitivity begin to be decreased as long as you continuously use the drug day after another. And it always occurs with beta 2 receptors especially. The most receptors that get mad at you when you keep stimulating them every day are beta 2 receptors in your body, because they experience tolerance quickly from these drugs. Okay? I mentioned the 3 T's, tachycardia, tremors and tolerance. The H. Now I want you to say it. What for does this H stand? It stands for hypokalemia. Blood potassium starts to be decreased. Why? Because I told you whenever anything stimulates beta 2 shifts the potassium from blood into the tissue. This is called potassium shift and it causes hypokalemia. Okay, now we have finished the selective beta 2 agonists. In the past, we had a drug that no one would tell you about these days. We used to explain it in old textbook thoroughly. Later, we removed it because it is no longer important for the students. This drug is called isoprenaline. Isoprenaline? Isoprenaline. Isoprenaline have another name. In MCQ exams, they may instead use the name isoproterenol. Isoproterenol. So, isoprenaline or isoproterenol are the same drug. This drug was a synthetic cat. Catecholamine, but synthetic. Why are we no longer using this drug more often? Because it stimulates both beta 1 and beta 2. Thus, it was termed non-selective beta agonist. And the term non-selective is always undesirable in pharma. We don't like any non-selective drug, unless it has a certain indication of course, but in most cases, we like to use more selective drugs. Now we have a drug that acts only on beta 1. Do you remember it? It's called Dobutamine and used for cardiogenic shock, as I told you. And I have drugs acting on beta 2. Do you remember them? The 5 or 6 drugs I mentioned before. What is the reason for using a drug that acts on 2 types of receptors? With each type of receptors come another adverse effects. Why would you use it? To stimulate beta 2? You have these. To stimulate beta 1? You have this one, and so on. That's why in your new textbook there are no information about this isoprenaline, except for being a non-selective drug. And we mentioned that it is rarely used. I repeat again. So don't you add 20 pages about isoprenaline. I see students add completely non-significant texts about it. We removed this for you, in order not to fill your head with nonsense, and because it is not commonly used. So if you find an old MCQ question in an outdated textbook from more than 10 years ago, you may find a question about isoprenaline. Indeed, from 10 years ago we used to discuss it in detail. Now we don't, because it's no longer significant. Thus, if you encounter such a question, don't burden yourself with further outdated information. We no longer ask about this drug. The only information you may need to know is that it stimulates both beta 1 and beta 2. That's it. We won't ask you anything more, because it's rarely used. Let's shift to the next family, which is drugs stimulating alpha receptors. Don't forget that we are taking it step by step until we finish a family called sympathomimetics. I started with adrenaline, we specified a whole video for it, and now we are explaining the rest of the drugs, other direct sympathomimetics. Me and you are illustrating drugs that stimulate the receptors. Now let's see those stimulating the alpha receptors. You can either stimulate alpha 1 or alpha 2 because you have two types of alpha receptors. Thus, if you say alpha agonist, which receptor of these do you mean? Or do you mean both of them? Okay, let's see the available drugs that are called alpha agonists. You will find that the first drug of the family stimulating alpha is called phenylephrine. Phenylephrine. And it is an important one. Beside it a drug called methoxamine. Methoxamine. Beside it a drug called midodrine. All in one line. The three of them, phenylephrine, methoxamine, midodrine, naturally, the three of them are non-catecholamines. Okay? So they are absorbed orally and so on. They stimulate alpha 1 and have relatively long duration because they last for about 2 hours in your body. When they stimulate alpha 1, they cause vasoconstriction. So what for do we use them? You told me exactly like noradrenaline. What did we use noradrenaline for? Didn't we use it to elevate the blood pressure? The phenylephrine, methoxamine, midodrine are also used as vasopressors to elevate the blood pressure via induction of vasoconstriction. They are present as tablets to be given orally, they are present as eye drops, and they are present as syringes. All forms are available, okay? Tablets are given orally 3 times per day to stimulate alpha 1 and elevate the blood pressure. But why are they present in the form of eye drops? Sometimes they are even present as nasal drops. So why are there eye drops and nasal drops? Because some people complain of red eye. Red eye means his eye is always congested, or he always complains of blocked nose from common cold or whatever, and he can't sleep. That's why we make them in the form of eye drops and nasal drops to produce vasoconstriction. If you are using them for red eye, apply these drops to the red eye and it becomes clear. Nasal decongestants are used when you have a blocked nose from congestion to relieve this congestion. But there is an important observation when we use these drugs. Indeed, they cause vasoconstriction, clearing the red eye and relieving the nasal congestion. However, they cause something called rebound. Can you tell me what does rebound mean? Rebound means that after 2 hours, these symptoms will return to you worse than before. Thus, after exactly 2 hours, if you use them for red eye, firstly, I'll tell you something funny. Once upon a time, during a wedding, the bride was nervous for some time. She couldn't sleep well, and during the wedding day, her eyes turned red. So she used these eye drops in order to have a clear eye for the photo session. By the time she arrived home, rebound congestion ensued, the red eye returned worse than before, the groom was terrified, and the wedding was cancelled. Same scenario occurs in the nose. When you have a nasal congestion and you can't fall asleep, you use these drops, then you have peace for 2 hours. 2 or 3 hours later and the congestion returns worse than before. This is called rebound. Why is that? What is the explanation of this phenomenon? In case someone asks you, if someone asks you why do these drugs cause this rebound, tell him look at this blood vessel. Here is a cross section, it was congested, dilated, causing problems. But when I used the drug, the blood vessels were suffocated due to vasoconstriction. From the prolonged vasoconstriction, the blood vessels become like this. From the prolonged vasoconstriction, metabolic waste starts to accumulate. You studied this in physiology. And you know that this metabolic waste causes vasodilation. However, as long as the drug is present, it doesn't appear, as the drug is causing vasoconstriction. And once the drug effect disappears after 2 hours, these metabolites take over these blood vessels, causing severe vasodilation, and the patient experiences congestion worse than before. This is the explanation of the word rebound. Okay, this is the first class of drugs acting on alpha. Exactly like the 3 drugs I mentioned are 2 drugs from a family called imidazoline derivatives. A drug called xylometazoline and oxymetazoline. Xylometazoline, oxymetazoline, from a family called imidazole. These two are exactly like the ones before. However, the difference is they stimulate both alpha 1 and 2 and they are considered non-selective. What are their uses? I told you alpha 2 effects are not prominent unless you target it with a specialized drug. Thus, their effects are like the ones before. They also act on alpha 1 causing vasoconstriction, and their main use is as nasal decongestants and eye drops, exactly like those I mentioned before. They differ in names, but they are treated the same way like the previous drugs. Now let's see the next group of drugs. But before we leave this part, I still have some notes in here. Glad you reminded me. I want to tell you about some notes under the title of, if you wish, call it adverse effects, that's okay. Also, if you want to call it precautions, no problem. And be aware they are important for the exams. These drugs, nasal decongestants or eye drops, this family of drugs and the previous one, are used so often without restrictions. People go to pharmacies and buy these drugs as if they were candies. People with common cold get these drugs over the counter without any prescriptions. And when it comes to the exams, we always give much attention to such drugs, because they can be dangerous if people use them carelessly. That's why we have a holy question that you can expect to see in any exam. It is the precaution of nasal decongestants, or the group of drugs called nasal decongestants. Which are drugs stimulating alpha 1? What are the precautions? We have 1, 2, 3. A question for 3 marks, and it's very often present. The first precaution. I told you that most of these drugs frequently cause rebound. What does this mean? It means that when you're going to use them, don't take a high dose, because anyway, once the used dose wears off, you get a congestion worse than before. So try to use the minimal effective dose, and try not to repeat it often, so you don't experience this rebound effect. Number 2. Some unfortunate people, when he apply these drops locally in the eye or in the nose, they undergo systemic absorption. He was hoping for a local effect, but unfortunately, the drug is absorbed into the systemic circulation, causing systemic vasoconstriction, which highly increases the blood pressure, probably into dangerous levels. There is still more to it. Even some people went through a stroke due to these drugs. Stroke means bleeding in the brain. A bleeding in the brain is called stroke or hemorrhagic stroke, to be more accurate. Some people experienced this. He applied the drops and went to sleep without knowing they could be absorbed systemically. They caused severe hypertension and caused a stroke. That's why I advise you to avoid using them frequently. Not anyone suffering from some nasal problems or congestion should use these drops. Number 3. These drugs, people who use them every now and then and get used to them, whenever they use them, they cause vasoconstriction. This prolonged vasoconstriction may lead to something called atrophic rhinitis. Atrophic rhinitis. Rhinitis means something related to the nose, atrophy in the mucosa. Why? Due to the prolonged vasoconstriction. You are inducing vasoconstriction for days and months. It's not for free. This mucosa will die from this prolonged vasoconstriction. After a while you may complain of anosmia. You can no longer smell, okay? And after some time, you may have chronic allergy, polyps, or many other problems. So these drugs shouldn't be used for a duration longer than 3 weeks. Longer than this, they could be dangerous. They could cause atrophic rhinitis. To summarize, the 3 precautions that you should never forget about are: these drugs could always cause rebound, and I told you what causes it and how it originates. 2. They could be absorbed systemically, causing systemic hypertension. 3. Prolonged use of them more than 3 weeks could lead to atrophy of the nasal mucosa, which is called atrophic rhinitis. That's why you shouldn't use them longer than 3 weeks. Let's see the next group of drugs which stimulates alpha 2 this time. Drugs stimulating alpha 2. Do you remember when I told you that alpha 2 effect cannot be prominent except when you specifically target it with a drug? Here we have 2 drugs. They are specifically alpha 2 agonists. The first one is called clonidine. The other, or its little brother, tizanidine. Okay? Now step by step. Clonidine, when you study the autonomic, you can note that it's mentioned later. In the autonomic chapter, there is only one line about it, but it tells you that it is explained later in detail. In the page 62 of your book. What's the story of this clonidine? This clonidine, in brief, a drug that functions by stimulating alpha-2. This is its function. And since it stimulates alpha-2, can you tell me where was it present? We said it's presynaptic. Do you remember what did it do? It decreases norepinephrine release. This alpha-2 here. When clonidine reaches this alpha-2 and binds to it, it decreases the norepinephrine in your body. It's decreased both peripherally and centrally, since this drug crosses the blood-brain barrier as it is a non-catecholamine. And when norepinephrine is decreased, then we can say this drug decreases the central sympathetic outflow. Focus on this term. So clonidine decreases the central sympathetic outflow, hence your blood pressure is decreased. And you calm down. The patient calms down. The patient who is nervous, hypertensive and anxious, all of this goes down. The drug relieves the patient from this. In addition to this, when the blood pressure is decreased, the renal blood flow is not affected. The drug decreases the blood pressure without affecting the renal blood flow. Why are we saying this? Because there are too many drugs when they decrease the blood pressure, they also decrease the renal blood flow and the GFR. GFR is glomerular filtration rate. This also starts to be decreased, thus urine output is also decreased and this is dangerous. That's why we are assuring you that this drug is acting centrally, it's acting on the nerve ending, it decreases the norepinephrine without affecting the tissue itself like kidney, liver or other. This encourages me to tell you that it's such a fantastic drug, as you can lower the elevated blood pressure of the hypertensive patient, especially if he was also a renal patient. If he has a renal problem like renal failure, for example, a patient with renal failure who is also hypertensive can benefit from this amazing drug which decreases the blood pressure without affecting the renal blood flow. Here you have this clonidine. The second use which we need this drug for, I told you once when I was explaining the introduction, something about drug addicts. The anti-emma is termed opium. This family of substances is called opioids. Opioids means substance related to this anti-emma. Drug addict uses these substances to get high. Ask him why do you take this? He tells you to get high. High on what? You don't know. But anyway, he's high. Okay, now when he tries to stop, what's the problem? He tells you I can't. I don't bear it. I get nervous and vengeful. That's why there are design programs for them, and I can help him with this nervous part, because when he stops using drugs he gets nervous and vengeful, and to get rid of this nervous and anxious behavior, I give him this clonidine. Clonidine decreases norepinephrine release in the nerve endings and in the central nervous system, so the patient calms down, or this addict calms down. As if this clonidine has two major indications. One of them, the first indication of it, is to reduce the blood pressure or to treat hypertension, especially in the renal patients with renal failure. 2. To help with opiate withdrawal or prevent opiate withdrawal. Which means when the addict stops the opiate or other opioid drugs, it prevents the effects that accompanies cutting the drugs off, and which we call withdrawal symptoms, like nervousness and anxiety and so on. These are its uses, so what are its adverse effects? We should always try to remind ourselves by using mnemonics. Adverse effects of clonidine are 3 S's. The first S is sedation. Sedation. The term sedative means tranquilizer. Sedation means the patient becomes sleepy all day. That's okay, no problem. Why? When the drug addict stops using the drug and takes his medication and becomes calmer and sleepy? Look, in Egypt we say the sleep of the tyrant is a worship. So this is beneficial and is due to the decrease in the norepinephrine. It also causes dry mouth. His throat is dry and this is irritating. But be aware that this dry mouth is not a peripheral effect. It's not an outcome of peripheral effect of the drug, but the central, and is not well known. Why? If you ask me what is its explanation, I'll tell you that it's the central effect. However, how exactly does this drug cause dry mouth? We don't know. Okay? The second S is for sudden withdrawal of this drug. Sudden withdrawal means stopping the drug abruptly. It causes severe hypertension. The most popular question about clonidine is this point. One of the most well-known drugs that should never be stopped suddenly. Sudden withdrawal means stopping the drug abruptly, which causes sudden severe hypertensive crisis. Look here, my friend. Nerve ending, norepinephrine, and you are given this drug for years, and this alpha-2 is working to decrease the norepinephrine. Now the body is accustomed to this. At some moment you stop this drug by mistake inducing a sudden withdrawal. What happens? What happens is this alpha-2 stops working. The norepinephrine starts to be increased, returning to its normal value, and more, so that patient could suffer from sudden severe hypertension. And the most common question about clonidine that we ask students in is this point. When we tell you one of the following drugs is very famous of not being suddenly withdrawn, which means one of these 5 drugs is very well known that it mustn't be suddenly withdrawn, shouldn't be stopped abruptly, then you must blindly choose clonidine. This last S is salt and water retention. It causes your body to hold on to water. And by the way, salt and water retention is such a large topic that will be explained in cardio. However, I'll tell you 2 lines about it to help you until we reach the cardio. We have a rule, my friend, which states that any drug whatsoever that decreases the blood pressure, if you continue to use it for periods about a month or longer, the body starts to induce a reflex sympathetic activation. The body starts to release something called renin-angiotensin system. You may remember it from physiology. Thus, any drug that lowers the blood pressure for long periods, after a month, the body starts to confront it with the renin-angiotensin system. To be more accurate, it was called renin-angiotensin-aldosterone system. Here in the middle, something called aldosterone, which causes salt and water retention. So, we will state a rule which says that any drug whatsoever that lowers the blood pressure for long periods and you intend to keep the patient on it, the body starts to confront you with what? The body tells you it won't abide your rule. I won't let you control me. You're lowering my blood pressure day after another. Then I'll let you face my renin-angiotensin system or renin-angiotensin-aldosterone, which induces salt and water retention. Why is the body doing this? The body does this as a form of reaction. You are lowering the blood pressure, so the body is trying to react. He's trying to fix what you are doing. The body doesn't understand what you are doing. You keep lowering the pressure by a drug, okay, then I'll hold on to the water to limit this decrease in the blood pressure. Accordingly, we are to use this term salt and water retention with any drug that lowers the blood pressure. From this moment, till the end of the curriculum, once you hear a drug lowers the blood pressure, then be sure that after a while, not today, but after a while, it will cause salt and water retention. Now, the clever doctor is the one prepared for this. So if he prescribes a pressure-lowering drug, he adds to it a diuretic. Diuretic means something increase in the urine in order to get rid of the water and prevent its retention. Again, clonidine is a very well-known drug, and it's also popular in exams. It stimulates alpha-2. What for are you going to use it? I use it to lower the blood pressure, especially in the renal patients. 2. It can help the addict to cut off his drugs. If he decides to stop his abuse, then I can calm him down with clonidine, as it decreases the central sympathetic outflow. What are his drawbacks? 3 S's. The first one is sedation. Sedation means the patient feels sleepy all day and dry mouth, which is not explained. As I told you, it's central, but its exact mechanism is still unknown. 2. Sudden withdrawal of the drug. If you stop the drug abruptly, it causes sudden severe hypertension. 3. It causes salt and water retention. And I told you, how does it happen? In brief, until we reach the cardio, and its treatment is to give a diuretic beside it. The next drug after clonidine, its little brother, which is called tizanidine. Tizanidine is a recently added drug to your textbook. It wasn't present in the previous edition. Tizanidine is exactly similar to clonidine. It also stimulates alpha-2. However, this time, tizanidine chooses to stimulate alpha-2 in, can you imagine where? In the spinal cord. Here is the spinal cord, and as you know, here there are something called anterior horn cells, which give rise to the motor nerve supply in the muscles. Tizanidine stimulates alpha-2. exactly like clonidine. However, this time, it chooses to stimulate alpha-2 only on the level of the spinal cord. Only. What does only mean? It means it doesn't act on the nerve endings, nor it acts on the brain. It only acts on the middle part, which is the spinal cord. When it acts on the spinal cord, on this alpha-2 here, you know that alpha-2 is always inhibitory, so when you stimulate alpha-2 in the spinal cord, it decreases the neuronal transmission, the neurotransmission, or the signal that is coming from the brain. When it descends to the muscles, it's blocked. And when the signal that's going to your body muscles is blocked, your body muscles starts to relax. That's why this tizanidine is a specific drug for alpha-2 in the spinal cord, specifically for inducing muscle relaxation. What is its uses? It's used in every disease that has a spastic element, muscle spasm. For example, from the prolonged use of your computer, laptop, or the mobile. You may not notice that by the time your neck starts to be stinging you, and there is a spasm in your neck. And when your neck hurts you and you go to your neurologist, he tells you it's due to the prolonged use of your mobile and prescribes you a drug that induces muscle relaxation in order to relieve this pain. This is one condition. Another one, say, people with a disease called multiple sclerosis. This is a rare neurological genetically determined disease. I'll tell you about it in the CNS. This multiple sclerosis causes severe muscle spasm causing muscle pain. Then I use this tizanidine for muscle relaxation. We give it orally, 1 tablet in the morning and in the night, 1 tablet in the morning and in the night. This is the dose, 1 tablet day and night. Any muscle spasm, any multiple sclerosis, any painful condition, someone with lumbar spine or cervical spine condition, any muscle spasm, anywhere, here is the drug called tizanidine. Naturally, it has many trade names, Zanaflex, Cerdalode, and many other trade names. 1 tablet day and night, okay. And your book doesn't mention its side effects. For undergraduates, it's just enough to know this drug is for the muscle. But take care for the MCQ. This drug is specialized in inducing muscle relaxation at the levels of the spinal cord. And you may have a question like this. One of the following drugs is used to relax skeletal muscle in painful spastic conditions. It mentions 5 drugs. Pick this one called tizanidine. The last drug in the family of the direct sympathomimetics, so in the next video we can talk about the indirect. The last drug we have is called fenoldopam. Phenol, pronounce it in 2 parts, fenoldopam. From its name, phenol means a phenol group. Dopam, oh. Now we are back to dopamine. Indeed, it's a catecholamine. Now we are back to catecholamines. This catecholamine is similar to its father which is the dopamine. However, this one is synthetic. Okay, a synthetic catecholamine. So now we are back to our old rules. This drug is not absorbed orally, it doesn't cross the blood-brain barrier, and it must be given parenterally by injection. What is the story behind this fenoldopam? This drug only stimulates dopamine type 1. It doesn't act on any other. And I've just told you at the beginning of the video where this dopamine type 1 was. Of course you still remember, of course you didn't forget, dopamine type 1 is present in the renal and in the mesenteric area. And its activation leads to vasodilation. Perfect, fantastic. So we are using this fenoldopam when we want to induce vasodilation in the kidney and in the mesenteric area, and when we want to lower the blood pressure. By the way, it lowers the pressure since you induce vasodilation in the renal and in the mesenteric. This is such a large area. When you induce vasodilation in it in a specific and selective manner, the drug only targets it. You don't just increase the urine outflow, but you also decrease the blood pressure. This drug is used by injection, intravenous syringes, in case of emergency hypertension. Emergency means an impending crisis. A patient that enters the emergency department with acute severe hypertension. There is no room for oral pills. He may not last for a while, so in emergency, give him this fenoldopam by a syringe. It immediately, since it is a catecholamine, and you know they are very rapid, once you use it, it immediately causes vasodilatation. The kidney increases the urine output, and his blood pressure gets lower. However, its only drawback, which is not written in your book, and which I want you to add, The only drawback of the fenoldopam, despite its short duration, why short? Because it's catecholamine. Its other drawback is that it increases the intraocular pressure. Thus, it's dangerous for glaucoma patients, patients with elevated intraocular pressure or with blue water. This drug is dangerous for them. Take care of this in order to avoid any confusion. This drug lowers the systemic blood pressure and increases the intraocular pressure. So it's used in cases of emergency hypertension to lower the blood pressure. However, it could be dangerous on the eye and it may cause sudden rise of the intraocular pressure, which is very dangerous on the glaucoma patient. Now, in this video, we have finished illustrating all of the sympathomimetics. Now we had two videos, one was only for adrenaline, the other video was specified for all other drugs that are called direct-acting sympathomimetics. In the next video, we will talk about the indirect-acting sympathomimetics.